Tēnā rā koutou e ngā hau e whā, ngā tuahine me nā tūnane. Whakapiripiri mai rā, whakatatatata mai rā. Ai o, ki te aorangi. Ai o, ki te aorangi. Kwa, 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 ki te aorangi. Kwa, 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 ki te aorangi. Aroha, ki te aorangi. Aroha, ki te aorangi. Hono, ki te aorangi. Hono, ki te aorangi. Welcome to the New Zealand webinar e te iwi e te whānau. Ngā tuahine, ngā tūnane. My brothers and sisters from across the world, come join us. Welcome. Thank you. Lovely to see you all. Tēnā koutou katoa. Kai a koe, Kevin. Next.
And next, thank you, Atos. Greetings. Kyoda. Welcome to this webinar and presentation of the sexual and reproductive health and rights of Māori living with HIV and their whānau in Aotearoa, New Zealand. This presentation is part of the 7-country Indigenous study involving Aotearoa, Canada, Nepal, Nigeria, Guatemala, Peru, and India. A study coordinated by the Canadian Aboriginal AIDS Network and funded by the Canadian Institutes of Health, supported by the World Health Organization Human Reduction Program and the IPP network. The karanga opened this webinar. In Maori tradition, the karanga signals a call to assembly, a call that connects the living and spiritual worlds. Steeped in tradition, the karanga epitomizes mana wahine, the power of woman. Tradition determines the style and format of our presentation today. Our tradition seeks to maintain a balance of dignity and respect for those assembled and what is shared. What is shared in this presentation has been carefully considered. English is the main language in this presentation, although Māori, kupu, or words will be sprinkled throughout the program. Next. English is information about Aotearoa New Zealand, Māori living with HIV, the presenters, a glossary of kupu Māori are available to view and download along with other reference documents for this presentation. Next, please, Ados. You will see from the program how we are going to do today's agenda, and I've advised the information that will be available for you to help assist you through this presentation. As mediator for this webinar, I trust this briefing has been useful. You will hear from me again for the question and answer session, so let's get started. I invite Jeff Ruine and Clive Espana to formally introduce you. But before we do, please be aware that the webinar will be recorded. You can submit your questions anytime. Please visit the website and download the handouts when you're free to do so. Nō reira, tēnā koutou katoa, nau mai hara mai, Jeff. Tēnā koe, Jeff. Next.
Kia ora tātou, me karakia tātou. Whakataka te hau ki te uru, whakataka te hau ki te tonga. Kia mā kina ki uta, kia mā taratara ki tai. Kia hi ake ana te atakura, he tio, he huka, he hauhunga. Ati hei, Maori ora. Tuatahi, e mihi kawana ki te kaihanga, ko ai ake mō tēnā mō tēnā. E mihi kawana ki ngā tūpuna, o koutou, o mātou, kua hui hui mai ki tēnei wā, ki te manaki, te kaupapa o te rā. E mihi kawana ki te hunga mate, rātou kua wehe atu ki te pō, rātou kua hinga no te mate ārai kore, haere, haere, haere atu rā. Ka huri au ki a tātou te hunga ora, ko koutou, kua haramai mō ngā hau e whā, ko mātou kua tai mai ki te kōrero. Kai te mihi ki o koutou maunga tapu, o koutou awa tipua, o koutou whenua tupuna. Kai te mihi, kai te mihi, kai te mihi atu rā. E rau rangatira mā, nau mai, haere mai, whakatau mai rā ki Aotearoa nei. Āpiti hono, tātai hono, ko rātou te hunga mate ki a rātou. Āpiti hono, tātai hono, ko tātou te hunga ora ki a tātou. Tēnā koutou, tēnā koutou, tēnā tātou katoa. Esteemed guests, colleagues and peers, brothers and sisters, it is my great pleasure to welcome you to Aotearoa today. I greet and acknowledge our Creator, whomever they may be for each of us. I greet and acknowledge your sacred mountains, your mighty rivers, your ancestral beloved lands. I greet and acknowledge your ancestors and our ancestors as they meet to shine their love on us all today. I greet and acknowledge our dead, near and far, and all those who have died from an age-related illness. We speak your names. I greet and acknowledge us, the living, those of us living with HIV and age-related illnesses, our friends and our whānau who stand by us each and every day. There is a Māori proverb that goes, he aha te mea nui o te ara, mā kue ki atu, he tangata, tangata he. What is the most important thing in this world? I will say to you, it is people, it is people, it is people. Blah is a term of endearment in Aotearoa, by the way. Welcome to this time, welcome to this space, welcome to Aotearoa. It is now my great honor to introduce Clive Espana. Kyoda.
Tēnā koutou, tēnā tātou katoa kua taimai nei ki tēnei hui ka nui te mihi atu nei ki a tātou katoa. Tēnā koe mili mō tō parana ki a mātou i tēnei rā. Tēnā koe Kevin mō tō mihi ki a tātou. Tēnā koe Jeff mō tō karakia i tēnei rā a tāhua. Nō reira ki a tātou katoa, tēnei te mihi atu nei ki a koutou, tēnā koutou. What a wonderful privilege to be here today. I want to acknowledge, first of all the people who have brought us together, and this really is an auspicious occasion. Briefly, I want to talk about the whakapapa, or the history that has brought us here today and has resulted in this wonderful webinar. Next. So some people here today will remember that in 2006, we launched the Toronto Charter. So the meeting, the reason for which we have joined here today has a long history that goes way back beyond 2006. But 2006 was a seminal moment in addressing HIV within Indigenous communities around the world. You'll remember at the AIDS conference in Toronto, we launched the Toronto Charter, which is an action plan to address the challenges associated with HIV within Indigenous communities internationally. And I'm sure some of you can recognize some of the faces here. One that stands out to me is Jeff Redding, and that looks like Renee mashing up there in the corner. So greetings to you all, and it's wonderful to be back with you here today. Next.
The Toronto Charter, as I said, is an action plan for HIV and AIDS. It goes back to 2006, and here we are, 2022, and we are now pleased to say that some of the actions that we have identified in that action plan are being played out right before our eyes as we speak. Next. One of the important things that happened since 2006 was a joint collaboration between Australia, Canada, and New Zealand. And to date, it's the only epidemiological study of a comparative nature across the 3 countries of Indigenous peoples living with HIV. And as you can see, these figures in red show that Indigenous people have higher rates of HIV than our non-Indigenous peers in the same country. And what stands out for me is Canada, Indigenous women in Australia, and here in New Zealand, Māori women with higher rates of HIV than non-Māori women. This study dates from 2011. That's 11 years ago. So one of the things that we might be able to look forward to is an update of this study over 10 years later to see if we've made any progress and whether things have changed. Next. So I just want to conclude by acknowledging all the people who have brought us here together today, in particular 3 countries, the funding agencies from the 3 countries that funded the tripartite collaboration that I've just referred to, Australia, New Zealand, and Canada. But I want to give a big shout out to the Canadian Institutes of Health Research, because we wouldn't be here today without their generous funding. And that funding has meant that we can meet internationally, that we can be pioneers and trendsetters in terms of the work that we do. And I want to give a special shout out to the people associated with the Canadian Aboriginal AIDS Network. And there are 2 people I want to mention in particular. And I know one of them is here today, Renee Mashing. You've done tremendous work, shown tremendous leadership in bringing us thus far. And also the other one I want to acknowledge is Carrie Martin, who's just emailed me to say that she cannot be with us today because she's home looking after her little boy, which is a wonderful thing to be doing. And I know she'll get to see this sometime later. I also want to give a big shout out to this organisation, the International Indigenous Working Group on HIV, and I want to mention in particular a wonderful leader associated with that organisation, and that's Trevor Stratton. Without the energy and the commitment of these people and these organisations, we wouldn't be able to sit here today and talk about these really important pressing issues. So I want to conclude by acknowledging all the people and all the agencies who have brought us here today. Thank you very much. Ngā mihi tino nui ki a tātou katoa, ngā mihi nui ki ngā rōpū tautoko e tēnei rā a tāua. Tēnā koutou. Next.
Kia ora mai, tēnā kōrua, mō kōrua nei mihi, ki te hunga ko tai mai tēnei rā. Thank you for your welcome. On behalf of those people assembled here today, and behalf of Manjula Narasimham, who unfortunately is unable to be with us live, but does have some words to share with us in terms of the overview of Health Guideline on SRHR of women living with HIV. So let's hand it over to Manjula. Kia ora.
this presentation is really to provide a brief overview of the key principles behind the development and you know, an overview of the guideline itself. It's a consolidated guideline on sexual and reproductive health and rights of women living with HIV, which was published in 2017. And it's really the outcome of a broad consultative process that involved, you know, national, regional, global experts that included healthcare providers as well as policymakers, program managers, particularly at country level, and UN agencies, ministries of health, national AIDS control programs, and particularly many networks of individuals and networks of people living with HIV, and that included representation from Indigenous women living with HIV. So the rationale and the scope of this guideline is really because many countries, women living with HIV do not have equitable access to good quality health services. And they are also faced with multiple intersecting forms of stigma and discrimination. And we hear about these stories over and over across most of the regions that we have encountered, and the women living with HIV, particularly from resource poor settings, are disproportionately vulnerable to violence and violations of their sexual and reproductive rights. So this guideline starts from the point when women already know that they're living with HIV, and acknowledges that for those who are not aware of their status, they must first be reached by safe, voluntary, non-coercive HIV testing and counseling. So although this guideline focuses on women living with HIV, we do also acknowledge that sexual and reproductive health and rights for many women in resource poor settings could be similar. But we are focusing here on the particular vulnerabilities that Indigenous women face with regards to being able to not only access quality healthcare, but being able to have a safe, supportive space in which their sexual and reproductive health and rights are acknowledged. Next slide, please. So this is just quickly to say that among the many leading roles of WHO is the mandate to develop high quality, evidence-based guidelines to support countries and communities. Next slide, please. And very briefly, what we mean by a WHO guideline is outlined. We do follow a process that's quite standardized, that's described in this handbook. And what we mean by recommendations are information that can be useful for policymakers, health workers, and also the end user, and in this case, women living with HIV. And it implies really a choice between different interventions. It's based on evidence, and it has ramifications for the use where there's limited resources. So there is issues related to cost and equity that come into play in each of the development of these recommendations. Next slide, please. And this guideline adopted a perspective that was, I wouldn't say unique, but that really grounded in the perspectives of women, their families, and communities. It adopted an approach that didn't start from what the expert needed to say, but what the women and the girls, including Indigenous women and girls living with HIV, had to say about their own sexual and reproductive health and rights. Next slide, please. And so some of the guiding principles are included on this slide. And first and foremost, like I said, it adopted an approach that is centered around the needs and rights of the end user of this guideline, which are women, girls, gender diverse individuals living with HIV. It really sees them as active participants, as well as beneficiaries of trusted health systems that respond to their needs, their rights, their preferences in holistic ways. It emphasizes the promotion of gender equality as central to the achievement of their sexual and reproductive health and rights. It in many ways requires that women are empowered with education, with support, to make and enact decisions in all aspects of their lives, and including in relation to sexuality and reproduction and HIV. So the guideline itself is organized around their health needs and priorities. And I'll get to this a little bit more in a minute. Next slide, please. So one of the key principles was about meaningful community engagement. So what was unique in the development of this guideline was a global survey which was conducted by and for women living with HIV to assess their priorities. And this was called a values and preferences. So it was a global survey, and some of the key aspects of this report, and this is the cover of the report, and the link is included here. So some of the key aspects was about the extent of the violence, stigma, coercion, discrimination that was systematically faced by women living with HIV, and the resulting mental health concerns. The report also highlighted the need for quality, respectful care within health facilities and in the hands of health workers, which was felt to be really lacking, in particular for those who are made most vulnerable due to their circumstances, and who are marginalized or criminalized or stigmatized in any way. Next slide, please. And so this is the framework for the guideline. And you can see the same image of the house that came out of the Values and Preferences Global Survey is at the center of this guideline. We place the needs and the rights of the women at the center. And in addition, you can see in blue the health interventions around various areas of sexual and reproductive health and rights. And in purple, the elements of an enabling environment that would be needed in order to implement the recommendations. Next slide, please. The sexual and reproductive health topics which are covered in the guideline align with the WHO Global Reproductive Health Strategy. So it includes some of these areas. I'm not going to read them out, but covers areas related to maternal health, family planning, sexual health, and STI, cervical cancer, and issues that are cross-cutting, such as gender-based violence. Next slide, please. And as I mentioned, the enabling environment also becomes really critical here. And we know that there are many challenges which we've highlighted, but the guideline attempts to provide strategies in order to improve and be able to create that enabling environment in order to implement the guidelines and advance the sexual and reproductive health of women. And that includes improving accessibility to quality services, acceptability of women themselves with relation to the recommendations and the services that are available, the affordability, the equitable coverage of these interventions. Next slide, please. And so the guideline includes recommendations, both for that enabling environment, which I just mentioned, but also specific health interventions around SRHR, which we just mentioned. And you'll notice that in the guideline, each of the recommendations, each of these sections include that little house that I noted before in the framework, because the voices of the women and their priorities were included in the development and in the wording of the entire guideline. Next slide, please. So there were recommendations, but there were also good practice statements, again, for the enabling environment, such as psychosocial support, such as the need for healthy sexuality across their life course, such as the need for protection from violence and social inclusion and acceptance, and also various health interventions, as we've already mentioned. Next slide, please. So the guideline was published in 2017, and this unique process of community engagement led to it being accepted as one of the gold standards in guidelines from WHO, and the establishment of a WHO advisory group of women living with HIV. It's the only community advisory group of WHO, and it includes representation of Indigenous women living with HIV. Next slide, please. And while we recognize that there are many excellent initiatives and programs and policies that already exist in countries, implementing these global recommendations and good practice statements really needs for it to be adapted to the local context. And in our experience in implementing this guideline, the communities which need far better care are Indigenous women living with HIV, are communities that include transgender persons, migrants, incarcerated people. And again, we hear about these stories and these challenges across many countries and many regions. And so having the guideline alone is a good start, but is not sufficient, and the implementation and the uptake of these recommendations at country level requires the partnerships and the support that webinars such as these provide. Next slide, please. I just wanted to share these words from Marama from New Zealand. You know, it has really been an honor to work with so many individuals and communities living with of women living with HIV in the development of this guideline, and we really continue to look to you and our partners on the ground to help us adapt and build the guideline better. The guideline now has a living format, which is a web-based format, in which we will continue to update and keep it relevant. And as new evidence comes, including through this research project, we will continue to update the guideline so that it will continue to evolve. Next slide, please. The next slide has, so this slide has the resources, which we hope that you will feel free to use and make available. It includes community-led strategies for the implementation of the guideline and case studies that was developed by and for women living with HIV. So please feel free to use these links or reach out to me for any further information. Next slide, please. So this is just my last slide, and I really wanted to thank everyone again, and really an integrated approach to health, to human rights, to gender equality lies at the heart of ensuring the dignity and the well-being of women living with HIV. I really look forward to receiving feedback on how best we can implement this guideline.
Nō reira, tēnā koe, Manjula. Thank you very much for your presentation. He Whānau Kotahi Tātou, achieving good sexual and reproductive health and rights for Māori living with HIV and their whānau in Aotearoa is the title of our presentation today. And so I would like to introduce Miley Stewart, who will take us forward with really the meat of our program today. Nō reira, tēnā koe, Miley.
Tēnā koe, Kevin, and o tira tēnā hoki tātou katoa. Ai, he tika tau. My name is Millie. I am Indigenous of New Zealand, and I live with HIV. I'm a new diagnosis, and I say new, it's only been 3 years. But in this process, you will hear from my team who all live with HIV, Margaret Kawana, Ben Black, and Jeff Duaine. And we are on the ground doing what we can possible for all of us living with HIV, not just here in New Zealand, but around the world. So ngā mihi kia tātou. Without further ado, I would like to pass the time over to Marguerite, who has an absolutely sensational, inspiring story and narratives to give over to you. Kei a koe, Marguerite. All yours, Marguerite.
Tēnā koutou katoa. Ko Ngāti Ruahine Tiiwi, ko Nunoti. Tēnā koutou katoa. Ko Ngāti Ruanui Tiiwi, ko Ngā Ruahine Te Hapu, ko Kawana Te Whānau. Hi, I'm Marguerite Kawana. I'm a mother of 2, a grandmother of 7, and a great-grandmother of 4. And I have been diagnosed with HIV for 30 years and has been living with it for 33 years. I didn't quite know where to begin my story, or because there's so much has happened in my HIV living life. I have fought battles with Human Rights Commission, as I have with doctors, nurses, dentists, paramedics, not to mention issues with the police force, employment courts, health and travel insurance, disclosure and privacy issues, and unfortunately family violence. So I thought it best to start at the beginning. 1992. I was a single divorced mother who was in a loving and compatible relationship with a man who totally adored me to pieces. I had just bought a house probably 6 months prior and had been working 6 days a week in a big retail store here in Christchurch in New Zealand, which allowed me to have a relaxed and comfortable lifestyle. In January, I was pretty convinced I was pregnant, so I went to my GP and it was confirmed. And even though I had 2 children of my own, it was my partner's first, and he was just so ecstatic to think that he was going to be a father. The news was quite uplifting in the sense that it was in a bizarre kind of way, because for the last year he'd been in and out of hospital with what the doctors had diagnosed as chronic fatigue, and which sort of hit him quite hard because he was a top sports person here in Christchurch. And at the time of my news about being pregnant, he was in a bad and negative space, so this helped him to actually focus on something positive in his life. So getting back to and being more precise, Friday, 14th of February 1992, it was St. Valentine's Day. I was called to my GP surgery. He had the results of my prenatal blood test, and the HIV test that he'd ticked on the form had come back positive. I knew he had ticked that box to be for HIV. It didn't bother me. I wasn't concerned and I had no issues with it. So as I sat in his surgery, before him I blabbered on. The only coherent words I heard was that I had 5 years to live. He finished his conversation by pushing a scrap of paper towards me, and as it was a Friday, there was no supporting organisations open over the weekend. And on that scrap of paper was a phone number, should I need it if I felt suicidal. There was no counselling, no support, no one to talk to, no informative pamphlets, nothing, not even Dr. Google. My partner was in hospital with pneumonia at the time. In a matter of a few weeks, he died of a HIV-related illness due to late diagnosis. It had been established that he contracted HIV as a result of a bike accident in Australia, and blood wasn't being screened back in the early 80s. A couple of weeks after burying my partner and the father of my unborn baby, I was coerced into having an abortion. Abortion is quite a harsh word. I think they use termination, but abortion it was. I was given 3 reasons for doing this, and the first one was because I'm a single mother living with HIV. The second reason was because I only had 5 years to live. And thirdly, who would want to look after an HIV positive baby once I'd died? At the same time, I had a tube ligation. After recuperating, I wasn't even back at work for a week when my house was raided by the police on the initiative of my boss, who accused me as a theft of a servant. I was then taken down to the police station where I was formally charged. My photo was taken, my fingerprints were, had my fingerprints taken as well, and then I was put in a cell while they processed the paperwork. With a good lawyer, and a very expensive one, after months of preliminary court hearings, I was found not guilty by a jury. The most alarming piece of information that came from this incident was that under court oath, my ex-boss had confessed that he knew I was HIV positive through his wife, who was a nurse on the ward where I had my abortion. All this happened within the first 9 months of my HIV diagnosis, and it was still 1992. Without sounding cliche, life was a bit like a roller coaster. I battled living with shame and low self-esteem. I'll never forget being spat on when disclosing to a friend. It was easy to pretend to be someone else so no one could get close to you and know the real you. Invisible walls and isolation was my sanctuary. But through all this, all through these early years, my rock, without him even knowing it, because I never told him I was positive, was my son. He was only 12 years old at the time. I didn't tell him because I wanted him to have a normal life. I didn't want him to look at me like I was dying. I wanted us to have a good mother-son relationship. He grounded me. He gave me a meaningful purpose to live and to keep living. He brought love and joy, happiness and laughter to our home. He was the reason I stopped crying silently at night in my bedroom. And even today, I don't think he realises what kind of impact he had on me. Back in the 80s and the first half of the 90s, HIV was close to a universally fatal diagnosis. Sex and death and homosexuality mixed together created a really terrible stigma, resulting in some really horrific discrimination. While it's improved since then, social attitudes don't reflect the enormous leaps forward in HIV treatment. And thankfully, abortion is no longer an option here in New Zealand. Global Equals You campaign has opened the door to couples regardless of their HIV status, and mothers have natural pregnancies and birth. And here in New Zealand, there have been no HIV positive babies since 2007, and that's using this U equals U format. Breastfeeding is a slightly more complex matter. The Ministry of Health here in New Zealand does not recommend breastfeeding, But if a woman does want to breastfeed, she must be fully informed and supported with her decision. And a couple of reasons the Ministry of Health doesn't recommend breastfeeding is that there's not enough evidence showing risk can be eliminated and safe, and there are other safe and effective alternatives. The advancement in medication has allowed us to live a much longer life, and as we age, I bet the 5-year death sentence, and we have other issues to look for, to put on our list, like diabetes, heart problems, dementia, and it's probably one of those illnesses that's probably going to take my life. I will still continue to take my meds and have regular blood tests that also include kidney and liver checks. But the biggest issue is stigma and discrimination. For Māori, and in particular Māori women, they aren't identified in any data or statistics of any meaningful comparison, and completely invisible in policy making in the welfare and well-being when living with HIV. I'm going to leave you with 5 words, and they are: HIV doesn't discriminate, people do. Kia ora, thank you. The end.
Thank you, Marguerite, for that inspiring talk. I know you are an inspiration to me, and I just want to acknowledge that, and you're a big part of my journey, so thank you. So I just want to enhance some of the kōrero or talk from Marguerite. From my perspective as a gay male Māori, and someone who's a little bit younger, yeah, so I'll just introduce myself. Ko tūhoi whakatohia me te whānau āpunu o ku iwi, he takatāhui kia ahau hioi ana anō ka noho ahau e roto I toku mana ake. Ko whakatane ahau e noho ana ko Ben toku ingoa. Kia ora, I'm Ben. I've been living with HIV for nearly 6 years, and I just wanted to tell you a little bit about my journey and some of the challenges that I have faced and noticed. So yeah, I was diagnosed about 6 years ago, nearly, and I first realized and faced stigma as soon as I got diagnosed. So when I was sitting with the doctor told me, oh, I didn't think you'll get it, and gave me all these pamphlets. One of them was HIV and the law, and she told me what I can do and what I can't do. So from then on, I immediately felt like I was a walking disease and a walking criminal. So the internal stigma was rife. At that time, the best place for me was my family, my whānau, which was also a huge decision for me to go back to, but the best thing ever. So that was probably the lowest point of my journey, because the internal stigma was so intense. And I think as Māori, the shame is a really big thing. So that internal stigma was really shame, which turned to fear, and that fear made me not come out of my room for at least 2 months. It was that bad. My family were really worried, but they were amazing. They didn't really understand it. They didn't really know how to support, but they supported me in other ways, and they took me in with open arms. Yeah, which was amazing. So, but I was very scared because I come from a very large and staunch macho whānau. My dad's got 15 brothers and sisters. I have nearly 100 cousins. So I was afraid because my diagnosis doesn't just affect me, it affects my wider hapu and hapuri, my community as well. So I was very afraid that they will find out and what they would think and how they would treat me. So there's layers of shame. So it took me a long time to come to terms with being takatapui or a gay male. So that once I sort of come to terms with that, there's also the shame of being a Māori sometimes. And then having the shame and stigma of HIV on top of that is a lot of different layers of shame. So what I realized is there was lots of different challenges along my journey, because I come from regional New Zealand where there is hardly any support, if at all. So in Aotearoa New Zealand, most of the support seems to be focused on white gay males, mainly in the bigger centres, which is Auckland, our biggest city. So when I reached out for help, it took a long time for me to get any kind of support, because I was challenging some of the norms. So they had to really dig deep and find some support for me. So by that stage, I sort of dealt with a lot of things myself. And also, I didn't want to do the kind of healing that was out there offered to me, because I wanted a bit more of a holistic approach. So I had to go and dig and search for that myself. So like midi massage, wider spiritual things, just to kind of enhance me and empower me. So I had to really suppress my grief. There wasn't really a place for me to grieve properly, there wasn't a great grief process for me. I had to work through all that myself. So I think there has been a lot to play here due to colonization that has really affected our journey here in Aotearoa New Zealand. So yeah, I'll leave you on that note, but I just wanted to end on a whakatauki, a Māori proverb, which Jeff also recited earlier, which is he aha te mea nui o te ao, he tangata, he tangata, he tangata. What is the most important thing in the world? It is people, it is people, it is people. And I say that as we are the protectors, we are the nurturers. We have a responsibility to ensure that moving forward, there is a fruitful and a pathway for our whānau. So there's nothing about us with us. So I'll just leave you on that note. Thank you for listening to me. I'll pass you on to Millie and Jeff, our next speakers. Kia koroa, Millie and Jeff. Thank you.
Tēnā koe Ben, tēnā koe Margaret. Nā mihi nui tēnei ki o koutou anō. Thank you very much, everybody. And yes, I'm part of the team, and I've been diagnosed with having HIV 3 years ago, so I'm a new diagnosis practically, and a late diagnosis, and I get and understand where that is. It was hard with all the discrimination and the stigma that both Ben and Margaret have spoken about, but I want to come to it on a totally Māori view, Māori worldview. I'm totally staunch in my culture, in my indigenousness, if you would like. So everything about what I do is about being who I am as a Māori, as a woman, as a Māori woman. And yes, all the stigma and the discrimination, the shame that comes along with that. But I am of a staunch background myself, and I fight. I stand and I fight. Not for only Māori women, but for all our sisters around the world who face the discrimination and the stigma. And without my whānau, without my family, because it is about family, for the support and the backbone that we need for our grounding to move forward. I was diagnosed 30 years after Marguerite. And at point of diagnosis, there is no change. A huge gap, 30 years down the line, and I still had to deal with the discrimination and the stigma. And in a way, it actually came from the medical team. So that is huge. And there's still no change. What is it that we need to do? We're human. Ko tātou ki tēnā. And I just also like to explain that in our Māori world, we need our Māori males for our balance. We have a holistic approach to our well-being that comes from our wairua, which is our spirit, our tinana, which is our bodies, our hinengaro, which is our minds, and our ora, which is our health. Without that all being intact, then we cannot operate. So therefore, having our men folk with us, with having Ben and Jeff with myself and Marguerite, gives us the strength to deliver our stories to you, the world, our brothers and our sisters. Whether you like it or not, you are our brothers and our sisters. So in saying that, I'm going to leave you with this whakatauaki. Kare te kumara e kia tiki tōna reka. If you know what a kumara is a sweet potato here in New Zealand. And you don't know how sweet it is until you try it. So no maira, I invite you all to come visit if you can, but not all at once. Because our country, though it's beautiful, we still have our issues, especially with this COVID epidemic that's going around and facing the world. Nai rei rei te iwi e te whānau o ngā haue whā, huri noa, tēnā koutou, kia ora hoki tātou katoa. Kei a koe Jeff.
Wow. Wow. Marguerite, Ben, Millie, I just want to say a big mihi to you guys. How humbling to be in your presence and to hear your stories. Kia ora e te ao, e te whānau. My name is Jeff. I'm one of the old guys. I got diagnosed this year, 30 years ago in July this year. Marks my 30th anniversary after a reckless, romantic liaison in New York City, of all places in the world. And then I contracted HIV, but I did not get diagnosed until 1996, 4 years later. So I'm mihi to all our brothers and sisters that have passed from HIV and AIDS over the years, all those that have gone before us, because especially those that spoke up, because back in those days it would have been a hugely difficult time to do that. So I got diagnosed 9th of August 1996, and from the moment I got diagnosed, I knew that I was in for a big journey because of the stigma and discrimination associated with HIV. I went and told my mum and my family first, and from the very beginning, my mum said to me, "It's okay, you'll be all right, we've got you. So I mihi to my mum, who also in July marks the 3rd anniversary from when she passed away. I mihi to my mother and my father for bringing me into this world and for providing me with a safe and loving childhood. And when I came out as gay to them, they still loved and embraced me. And then when I came out as HIV, they did the same, and they still did the same until today. My dad, I live with my dad at the moment, and yeah, I can't speak enough about the power of whānau and family. After being diagnosed, I felt fearful, scared, because back in those days, medication and treatment still, we hadn't come very far. So in 1996, the combination therapy came out. So I started on those straight away, 25 pills all up, around that I was taking. So really, when I got diagnosed, I was given hope from day one. So with that mindset, I felt that I wasn't going to die anytime soon, although there was that scary time. It is a scary time. Shame, I felt very ashamed. I felt very guilty. I went to my first hui takatapui, the Māori gay gathering, where I learned about the Positive Speakers Bureau, and that's, most countries have them, and that's the organization made up of people living with HIV from all walks of life who get to share their story. At first, when I was invited to participate, I was dead against it, because there's no way I could speak in front of strangers and talk about not only being gay but being HIV as well. But after doing the workshop and meeting my first woman living with HIV, hearing my first story of a person living with HIV, it completely changed my attitude. And I thought, wow, the power of your own story. And in our cultures, Maori, and my dad is from the Cook Islands, and Maori and Cook Islands, Pacifica cultures, the telling of our stories, it comes naturally to us. And it's the way we communicate, it's the way we pass on our legends and our mythology. And when I did my first talk, and the power that it had in terms of educating my own people, I was just blown away, and I knew that I could take this somewhere and do something good, which put me on the pathway of HIV advocacy. So I've been doing positive speaking now for the last 25 years, and working for the New Zealand AIDS Foundation for 10 years as a health promoter with the Māori program. Meant that I got to travel. I got invited to the Cook Islands to be the first Cook Islander to speak publicly about living with HIV, which was a deeply humbling experience. I've met the most amazing, beautiful people with incredible stories to tell and to share. I'm just been absolutely blown away. You know, as Māori, the telling of our stories is one of the most powerful educational tools that we have. And I think at every single moment, every opportunity that we have to tell our stories, we've got to be out there and doing it. So I'm here to my mates who have just been on, because we're about to embark on this great journey of this new Māori living with HIV organisation for Aotearoa New Zealand. I thank all my whānau being your loved ones, your blood family, your friends, those that you hold close. For without them, I wouldn't be where I am here today. I'm currently a registered nurse. I work in a mainstream GP practice. We're being smashed by COVID at the moment. And it's a humbling work. It's a humbling job, and I'll always give myself and what I can to the kaupapa. Yeah. So, in closing, I want to just give a quick mihi to my mates. E rau rangatira mā, nā te atua tātou e tiaki mai. e te whānau. Thank you for being part of our presentation today. And to all the people watching, nō reira, kia ora, kia orana. And it now gives me great pleasure to introduce our next speakers, Alison Green and Gillian Tipene. Kia ora rā.
I would like to acknowledge the speakers that have just shared their stories, our colleagues from Toitu Te Ao, who are working in partnership with us on this study. Very powerful, very inspiring. Tēnā koutou. Can I have my slide, please? First off, speaking about the sexual and reproductive health and rights of Māori living with HIV in Aotearoa, the situation in general in New Zealand is poor in terms of sexual and reproductive health of Māori living with HIV. Particularly poor, or poor for all New Zealanders in general in terms of STI outcomes, teenage pregnancy, but for Māori even more so, and then for Māori living with HIV even more so again. And that's due to factors such as poor access, isolation, health system barriers, and a huge issue is stigma and discrimination. Added to that, in terms of rights, there's no recognition of Māori rights-based approaches in Aotearoa. Initially, we have inherent rights as human beings, of course, all Māori living with HIV. And those are reinforced by our individual, or people living with HIV's individual and collective rights under our treaty partnership agreement with the Crown, Te Tiriti o Waitangi. These include the right to equitable health outcomes and good sexual and reproductive health, and freedom from stigma and discrimination. And these collective rights of Māori living with HIV are further strengthened by the UN Declaration on the Rights of Indigenous Peoples. And although New Zealand is a signatory to all these agreements, the sexual and reproductive health and rights of Māori living with HIV are not prioritised because these rights agreements are not well understood by health and social services, and they're not recognised in policy in Aotearoa. Looking at the data on sexual and reproductive health and rights of Māori living with HIV, if we look at the latest statistics from the AIDS epidemiology surveillance newsletter for the year 2020, we can see that there's a number given there of the number of Māori ever diagnosed with HIV in Aotearoa to date. We can see that by far the largest group of those notified in 2020 were men who have sex with men. And of those men who have sex with men diagnosed in 2020, 8 were Māori. But in general, we're not getting enough information about what's happening with Māori living with HIV. Research shows, and anecdotal evidence also shows, that surveillance data relating to Māori are likely to be an undercount. Numbers of Māori people living with HIV that are recorded are influenced by things like late presentation to diagnosis, the marginalisation of communities such as Māori people, Māori trans people, and HIV-related stigma and discrimination. All these factors really impact on the true recording of the numbers of Māori living with HIV. Late diagnosis of HIV, Millie spoke about that, particularly amongst people 50 years and over, is being highlighted recently in research publications and is an issue of real concern for Māori people living with HIV. So there is an urgent need for more rigorous collection and reporting of data relating to all communities of Māori people living with HIV. And for that data that is collected to reflect the priorities of Māori living with HIV communities. I want to ask a question, what's changed in the last 27 years? So 27 years ago, there was the first ever Māori national hui on sexual and reproductive health and HIV and AIDS. It was held in a marae, a Maori cultural gathering place in Auckland in New Zealand. And at that hui, at that gathering, many of these issues were discussed at length, that Māori were at high risk of infection, that there was a need to eliminate HIV-related stigma and discrimination. There was a need for more education and attitudinal change, for better understanding of human rights for Māori living with HIV, for community-led approaches and solutions, and for more funding and resources into those communities. So the question is, and it's actually been asked already in some of the sharing of people's personal experiences, has anything really changed for Māori living with HIV in the past 27 years? Recently, our organisation completed a research project and produced a Māori participants report, which is actually available to you to download in the handouts provided in the control panel there. It's a report on Māori participants from the Aotearoa People Living with HIV Stigma Index study. And in that study, in the report, we found that Māori living with HIV, some of them for 2 or 3 decades, had in fact seen no change in their experience of stigma and discrimination and abuses of their rights, including sexual and reproductive health rights, in all that time. So there's a couple of excerpts from the report up there on the screen. This is an international, the HIV Stigma Index is an international survey that many countries have completed. We believe our country to be the only one that has done a separate investigation of the Māori dimension of our wider project of Stigma Index measurement of people living with HIV. And although it was predominantly quantitative in terms of it being a survey, there was a small amount of space for people to make some comments. And so these qualitative quotes are drawn from that part of the report. Yes, they speak for themselves. So that's enough from me. I'll pass you on now to my colleague, Alison Green. Kyoda.
Tēnā koutou katoa, tēnei te mihi ki a koutou, ngā iwi take o te ao whānui. Ki a koutou ngā wāku hoa, tēnei te mihi ki a koutou. Kevin, thank you for bringing the webinar together. Millie, Jeff, Ben and Marguerite, for your lived experience, your knowledge and your commitment to yourselves and others, other Māori who are living with HIV, and also in the context of whānau. Thank you, Gillian and Clive, for your setting out the background in terms of Aotearoa's engagement, or actually lack of engagement, for Māori who are living with HIV, and also preventative work to reduce the likelihood of transmission of HIV amongst Māori. Next slide. So I'm going to talk about some of the challenges and opportunities present in Aotearoa, particularly focusing on policy and practice, and then I'll make some statements around around operating the sexual and reproductive health and rights guidelines. And of course, we'll, as part of our study, we'll be looking at these issues more deeply. But there are a number of challenges and there are some opportunities, but I had to think very hard and positively about what those opportunities might be, because right now the situation in Aotearoa in terms of Maori living with HIV is bleak. And a number of my colleagues have talked about the stigma and discrimination, the racism and the marginalisation that they've experienced. So with that as a background, it's no surprise to know that the voices of Maori living with HIV have been almost entirely absent from policy development. In 1995, the first ever and the only ever government-funded hui focusing on Maori and HIV, the messages, as Gillian said, were clear in that report. There's been no engagement with Maori living with HIV or the issue of Maori and HIV since 1995, and so the policies that we've got have been woeful. So there's also been no engagement of rights in that sexual and reproductive health policy development. So most recently, myself and other members of my organisation, Te Whāriki Takapau, were part of a Ministry of Health working group around drafting the HIV/AIDS HIV action plan. No Māori were engaged in that process of developing the action plan, and actually people living with HIV in Aotearoa who weren't Māori also had to struggle to be part of that policy development process. So in other words, rights weren't being engaged as being the primary basis for developing HIV policy. So the other major issue for us, which is why this study is so important, I think, is that there's very little data collected about Māori and HIV. So there's been one research report in 2010 about late diagnosis in Aotearoa generally, and in that paper, some attention was put on late diagnosis amongst Māori, but there's been nothing done since. And because there's no interest in pursuing the issues like late diagnosis of HIV amongst Māori, or inadequate sexual and reproductive health services for Māori men and women living with HIV, there's no interest then to collect the data. And so if that's to change, we're going to need to really focus in on what the barriers are to collecting that data. And that will involve us addressing racism within the health system. So in 2020, the health sector of New Zealand was in front of a tribunal to look at the barriers for Māori, that's all Māori, with regard to health services, and racism was determined as one of the primary barriers. So, you know, that's not good news for New Zealand, and that might be a surprise for some of you listening to this a webinar, because New Zealand often presents itself as being a country that's got good race relationships and as being high performing in terms of quality health services for all, but that's not the experience of Māori. So opportunities, as Gillian talked about, we had Aotearoa was the first country to produce an Indigenous HIV stigma index report. I'm really keen to hear about, you know, what the barriers might be for other countries producing a report about, based on the stigma index, about the Indigenous peoples within their countries. So those are neat conversations I think that we can have, and conversations which would strengthen our resolve, certainly in Aotearoa, to improve the stigma index. So we need to customise it, but the priorities need to reflect those of Māori living with HIV, and Māori living with HIV need to be actively involved in the customisation process. As you heard, Toitū Te Ao is the first and only, well, no, sorry, it's not the first, but at the moment it's the only organisation representing Māori living with HIV. So it's an organisation by Māori for Māori living with HIV. In the early 90s, there was a Māori organisation that was set up with similar advocacy and research interests. And like many things in the health sector to do with Māori, the funding dried up and that organisation ceased. So did INA HIV, which was the Māori organisation that Marama Mullen represented. So Toitū Te Ao, it's so great to have the organisation with us, and we will be making sure that what happened to the other Māori organisations is not something that will confront Toitū Te Ao. So we need metrics that are supported by Māori living with HIV, and we need to address this issue of late diagnosis. In New Zealand, we're about to go into a big restructure of the health sector with for the first time ever, a Māori health funding authority. That initiative was proposed in the 1995 HIV and Māori report that Gillian talked about. But here we are in 2022, and finally we've got a Māori health authority. So whānau ora is going to be a key policy approach, and we will be working with the new Māori health authority to ensure that we get a rights-based approach in there as well, and that in terms of Māori living with HIV, that it's their rights that are primary in any conversations around whānau ora. So thank you for the opportunity to present, and I'm going to hand to Kevin.
Kia ora mai, Alison, no reira, hoki te mihi ki nā kōrero hia, e aku hoa, no reira tēnā koutou katoa. Greetings to you again, greetings Alison, greetings to all our speakers, and for sharing their stories and for sharing some of the opportunities, challenges that are required in terms of our study here, in terms of advancing Māori living with HIV and their needs in New Zealand. We're at the stage where we have whakawhiti kōrero ngā pātaitai, so it's an opportunity for discussion to any questions that are being asked from our audience. I have a question that I'm going to direct to Clive Espana. So Clive, HIV has been around for 40 years and we still have problems with the collection of Māori and Indigenous data. What do you think needs to happen to improve data collection processes? And if Clive's not there, then it could pass on to, no, Clive, no, Clive.
Kia ora, Kevin. Kia ora. Thank you for that question. This has been a problem. It's been a problem for 40 years. New Zealand never started collecting Māori data until about 15 years after HIV first appeared, and we still have significant anomalies. We know right across the health sector that Indigenous people get undercounted and underreported, but this has never been taken into account with regard to the collection of HIV data in New Zealand. So it's not unique to New Zealand, but it definitely is something that needs to be addressed. And I'm hopeful that this project might help to find ways and processes for us to address this really important issue. Because if we really want to know how Māori are being affected and by HIV, we do need robust data collection systems. And with all due respect to those who've been collecting data for the last 20 odd years, there still is room for significant improvement. And one of the ways to improve data collection is to involve Māori in the collection of the data, and then to give Māori the right, or to recognise the right of Māori to look after that data and to use it in a way that is going to enhance the health and well-being of Māori communities throughout the country. We're seeing really high rates of COVID among Māori and Pacific people in New Zealand. Over 50% of all people with COVID, diagnosed with COVID, are Māori and or Pacific, and Māori only make up 20% of the population. Pacific people make up less than 6%. So we're seeing significant disparities, and that needs to change. We just need to see greater involvement of Māori in the collection processes, and we need to see involvement of Indigenous people in other countries involved in the collection of data, so that it's done in a robust and timely manner. Thanks for the question, Kevin.
Kia ora, Clive. I'm going to pose a question to Millie. Why is it important for the voices of Māori people living with HIV to not only be heard, but how do you think it could be, how do you see it being presented in a way that you actually see changes being made, you actually feel changes being made to the issues that Māori living with HIV and their experiences are saying? Tēnā koe, Millie.
Tēnā koe, Kevin. Thank you for that. And nā mihi ki anō kia tātou. That's a big question, Kevin. We know our Māori people and how stubborn they can be. But I honestly think the approach needs to come from those that know and understand those that are going through it and understand where their positioning is out, knowing how they're feeling, knowing what they're needing, and just having that conversation as I think it was Jeff that said it's about communicating, about having that conversation. And, you know, as an Indigenous Māori woman, I don't put up with very much if it's not going to help me move forward. And having a holistic approach, a more cultural approach and understanding that you're not just dealing with the individual. Yes, we are, and that's huge, but we're also dealing with their whānau, with our whānau, with their tupuna and our tupuna, It goes beyond what it is just in front of us. So, kairero tēnā, Kevin, under that, Parirau Aroha, the wings of Aroha, hei manaaki here to support and embrace everything, our holistic approach of that person. Koina tā mātou mahi, e Whānau ki Tātou te iwi Māori. And we extend that to all our Indigenous, because we all have a culture and we all have those concepts and those principles as Indigenous. Nā reira, tēnā koe.
Tēnā koe, tēnā hoki koe, Millie. I have a question that I'm going to pose to Alison. And one of the things that came out of the kōrero today was Jeff saying, you know, stories really matter. It comes easily to us as Māori and to Pacifica Whānau. And so how do we, what do you think we need to do to make those stories also apparent in the data, so that it means it's meaningful also to the people with lived experience who are normally like to listen to the oral experience and data that comes from there? Kyoda, Alison.
Kia ora, Kevin. And yes, thank you, Jeff, for raising the issue of pūrākau and the pleasure that our communities get in both sharing stories, but also receiving information through stories. We're in a difficult position. I think that we need the stories, and I think we also need the statistics in order to be able to move forward. So in our communities, pūrākau or stories certainly are an effective way of providing information and advocacy about services that are needed, but also the success stories, to talk about the Ben and Jeff both talked about the important role that their families played in their well-being after diagnosis. And I think those stories are uplifting and positive and very useful. But I also say that for health services, we need the statistics in order to change the way that funds are allocated. And we need to use a rights-based approach through that process.
Kia ora, Alison. Thank you for your response to that question. If I could go on to the next slide, please, because we are coming to the end of our presentation. But there are some things that you can look at in the days to come, remembering that this recording will be shared shortly and is available online at https://can.ca. I hope you were able to read that. But anyway, the main thing is the presentation will be available in recording. If we could let the next slide also, please. And of course, you can go to these websites or to Facebook to get more information about the organisations that have been in this presentation today. Remembering also that there are attachments to this webinar that you are able to download also in terms of obtaining more information. Our presentation today came from presenters who are all over the country within New Zealand, and so I do thank them for their time, and I do thank you for listening. But there are some closing remarks that I'd like to address with the next slide, please, and invite Millie and Clive back to share some closing remarks. And the closing remarks are in response to a question, which is, if there is one thing that you would like the audience or those who are going to listen to this presentation today to take away from this presentation, what would that one thing be? Or if you've got two, you can do two as well. Kia ora. Millie.
Hey, tēnā koe, Kevin. And I guess what would be really great to take away from this webinar from Aotearoa New Zealand, the heartbeat of the world, is to understand that we do also go through a lot of the issues that other Indigenous women go through, that we share a common space. And that Alison brought up the misconception about New Zealand being the wonderful getaway, and there are gaps, and those gaps need to be addressed. So in saying that, I'll leave the rest up to, I'm not so much on the data and the statistics type of person. I'm going to leave that to Clive. So ngā mihi, Clive.
Ngā mihi ki a koe, hoki, Millie, thank you so much. There have been some powerful voices here today, and it has been really edifying to hear the voices of people living with HIV coming through so strongly. My overriding message is that we can deal with stigma and discrimination, so that people with HIV no longer experience stigma, discrimination, because that for me has been a prevailing message that I keep hearing today. And it is very, very sobering and distressing to think that not much has changed in the 40 years that we've been living through this pandemic, that it still is a factor in people's lives. Let's see what we can do as a really powerful consortium of 7 countries. Let's see what we can do to break down some of those barriers. I want to acknowledge the people who have spoken today. Marg, Millie, Jeff, Ben, your stories are really powerful, and I'm so pleased that you are here with us and that you're on this journey towards making the world a better place for people living with HIV. I want to acknowledge also our partner countries, Nigeria, Peru, Guatemala, India, Ecuador, and of course, Canada. We have so much to learn from one another that over the next 4 years, let's embark on this exciting journey to make a real difference for our countries, for our whānau, and for the communities that we belong to. We have so much to learn from one another, and this is just the beginning of a really exciting journey. Thank you everybody so much for all you've contributed today.
Kia ora tātou. So we've come to the end of this particular presentation today. I also wanted to add India and Nigeria to that list of countries that was mentioned. I want to just direct your attention to the core 55 pattern, or the pattern that has been appearing on our slides throughout the presentation. It is a traditional pattern. It is a pattern that represents the hammerhead shark. And the meaning of the hammerhead shark being represented is that it's known for its stubbornness, fighting qualities, and so forth. And so the meaning of this core 55 pattern, which is called mangupare, is strength and endurance, which highlights really well the stories that have been told today and the challenges that we have ahead, but with strength and endurance, we will get there. So, in that being said, I also thank all the presenters, everyone who has assisted with us to bring this presentation together. And in closing, I have a karakia, which is our way of closing the hui, and the webinar will finish once I conclude. Kia whakairia te tapu, kia wātea ai te ara, kia turuki whakataha ai, kia turuki whakataka ai. Haumi e, hui e, tae ki e. Tēnā koutou katoa. And the last slide, please.